You're listening to Medscape's In Discussion series on bipolar disorder, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Trisha Suppes. Dr. Suppes is a professor of psychiatry and behavioral sciences and the director of Exploratory Therapeutics Laboratory at Stanford University School of Medicine. She also serves at the Palo Alto VA as director of the Cooperative Studies Program Network of dedicated enrollment sites and a staff physician. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hi, I am Trisha Suppes, and I want to welcome you to Medscape in Discussion Bipolar Disorder podcast. Today we're going to focus with our guest on neuromodulation and psychedelic potential use in bipolar disorder. So the focus will be on rapid-acting therapies, both some that we know about and some that we're learning about. So first, let me introduce my guest, Dr. Scott Aaronson. Dr. Aaronson is Chief Science Officer at the Institute for Advanced Diagnostics and Therapeutics at Sheppard Pratt, and as well, he is an adjunct professor in the Department of Psychiatry in the University of Maryland in Baltimore. So thank you very much for joining us, Dr. Aaronson.
Thanks for having me. Delighted to talk about this topic.
So I'd like to just start by asking you, what's your thought on neuromodulation, the rapid acting? There's a number of them, and I know you've had a lot of experience doing research and working with them clinically. So what's your thought in terms of some of the neuromodulation techniques for bipolar disorder?
I'm somebody who has always focused my interests on difficult-to-treat mood disorders. I think the most underserved population are those folks with bipolar depression. We've got very few clearly effective treatments, and the effective treatments in bipolar disorder have tended to focus much more on the high side than the low side. So we really don't have a lot of specific medications or interventions for bipolar depression. So I didn't necessarily expect to become a device guy, but several years ago, when I first got to Sheppard Pratt, I've been here since 2001, and was starting a clinical trials program that was very, very little novel within the entire mood disorder space for depression. And what happened is I wound up as a rescue site for the original transcranial magnetic stimulation, a TMS trial that Neuronetics was doing, and also took over a number of patients for vagus nerve stimulation who were already enrolled in the University of Maryland.
Could you just say a little bit about vagus nerve stimulation? Because I don't know that everyone will be familiar with that.
So vagus nerve stimulation is an implantable device. It's implanted in the upper chest. Leads are tunneled under the skin and wrapped around the vagus nerve, right around where the recurrent laryngeal comes off the vagus nerve, right in the neck. What we're trying to do is create some activity in the neurons that are going upstream. And what's really cool is if you hit the vagus nerve going upstream, where you run into are things like the nucleus tractus solitarius. And from there, we actually hit most of the major areas in the brain that are responsible for the production of all three important mood disorder-related neurotransmitters. So we can improve the production of norepinephrine, serotonin, as well as dopamine. It's been a little bit frustrating in the whole field with VNS because there have been a couple of different studies that have not separated from either sham treatment or low-dose treatment, largely because we didn't know enough to make the studies conclusive. So the original study, which was completed around 2005, didn't separate, and it didn't separate between the folks who were implanted but not turned on from the folks who were implanted and turned on, largely because our primary outcome measure was just 8 weeks after we turned the device on. So we learned that it had to be a longer period of time, and then a second study, which was a dose-finding study, in which we randomized people to low, medium, or high-dose treatment, and here we learned our lessons somewhat and had a primary outcome measure out at 6 months. But we still managed to screw it up because what we did is we found that even low-dose treatment that's offered for 6 months is effective enough that there again, we didn't separate from the medium or high dose treatment, but we were able to collect lots and lots and lots of data. So I was the lead investigator for that dose finding study and was also the lead investigator for a follow-up study, which was a large depression treatment registry. And these were all folks who had failed multiple treatments. So these are all folks who had failed at least 4 treatments in the current episode of depression.
Right. So VNS is not something you want your psychiatrist to do. You need a neurosurgeon or similar to implant it. I did a series quite a while ago with Lauren Marangel in bipolar disorder. And I'm curious because what we found with VNS is it sort of brought the floor up. People still could get depression, but it didn't go as deep or profound. And as you were saying, it took 6 to 12 months to really see the full effect. Have you had other experience with VNS and bipolar disorder?
Yeah, and so within these studies, we allowed unipolar and bipolar patients. So from the large registry-based study, about 22% of our folks had bipolar depression, and the other 78% had unipolar depression. And actually, if you look at it arithmetically, the bipolar depressed people did better actually than the unipolar depressed people. It didn't separate statistically, but it did separate arithmetically. And the other thing that's really cool is we actually see pretty profound changes in, as you're saying, in the baseline for a lot of these folks. And so what you can do is you can create a much higher baseline than they're existing with, and then you can throw other things on top of it to get further improvement.
Right. They continued on meds in my experience, but it was as though their brain was more sensitive to the meds. I don't understand that, but that's clinically a bit of what we saw.
You're likely going to be increasing neurotransmitters, not just as reuptake blockade, but what we can find, and, if you want to extrapolate from rat studies, is when you're looking at rats, you actually can see an increase in CFOS, which is a marker for production of neurotransmitters. And there are also some studies, actually there was a couple of interesting studies from the early research that suggested that people who had VNS turned on actually also had higher amounts of these monoamine metabolites in their CSF.
I'm interested in VNS, and you are as well, and we think it is an option potentially for people, but it's not the main thing people are doing right now.
It's not, but I think that there are so few treatments for folks really far down the spectrum who failed everything. We're only looking at bipolar folks who have failed at least 4 treatments. We're still currently enrolling in a large multi-center study that's funded by CMS, by the Centers for Medicare and Medicaid. We have finished the unipolar part of the study, and we're still enrolling folks in the bipolar part of the study. But my clinical experience has been that I can make a whole lot of people better I haven't been able to make better.
It's not a cure, but like I said, I feel like instead of going to sub-basement 3, they're more like in the basement right below the floor. The depression isn't as dense. It's not as intense. They feel they can cope better. They still can get depressed, but they feel like they're not out of control and overwhelmed. That's interesting. Well, where do you see rTMS? It's another rapid-acting therapy that, of course, is gaining traction, trying different methods of stimulation, frequency and repetition, and so on. What's your view on TMS for bipolar depression?
It's one of those things that there's been really a schism between clinical treatment and what's happened in the very few studies that have been done. So some of the studies have been somewhat equivocal. The largest study was something that Lakshmi Yatham's group did and reported on. I think Alex McGeer may have been the first author, and it was a trial of this very rapid stimulation called intermittent theta burst that they wound up ending the study in a futility analysis between the folks getting sham treatment and active. I have seen clinically, though, people getting better with the standard TMS protocol. And so I have one article from a couple of years ago, maybe 2020, in which we looked at just who we were treating clinically in our TMS service at Shepherd and found that most of the folks we treated got better, and we had a better likelihood of response or remission than we did with the unipolar group. Then I was able to get some philanthropic funding to look prospectively at 30 patients with bipolar type 1 or type 2. And there, too, we got pretty substantial numbers in which we're looking at over 80% of these folks met remission criteria. And these are all folks who'd already failed things. And it was not just at my center, so my buddies over at Mayo Clinic were also at the site for this. This paper is currently in press at Journal of Clinical Psychiatry. I'm just waiting for the proofs to come back. And the problem has been is that we have not found willingness to fund a large randomized trial that will finally get this as a clear treatment for bipolar depression.
How long was the follow-up in the study that's in press?
Generally, I'm only reporting on the response over the first couple of months of treatment. We're trying to get our data together. I do have data out to 6 months after treatment. And admittedly, there is a higher response rate and a somewhat more rapid relapse rate than you'll see with unipolar. But that's kind of to be expected within this population.
You referred to the Lakshmi-Yatham study. Can you just say a little bit for our audience about what a futility analysis is?
Yep. A futility analysis is a lot of studies have a built-in ability to analyze data when you haven't finished doing the study to see if statistically you are likely to see separation at the end of the study if it's continued. And you can do two types of analyses. Either when you're in the middle of enrollment, you'll decide, well, it looks like one group is doing much, much better. Let's do an analysis. And we may do an analysis that finds that it's not worth finishing because you've actually separated already. And in this case, they found the opposite, which was that even if the study was done to completion, it would not separate just because there was no evidence that there was an element of separation at the midpoint of the study.
Thank you. That's very helpful. So that leads to someone needs to do different stimulation techniques on the population. That's a study waiting to happen. But it's very encouraging to hear what you've seen with more standard TMS because it's non-invasive. People don't have anesthesia. There's very few side effects. And if they are there, they're transitory. So I think that's a hopeful potential option for some people. Is it covered by insurance now for bipolar, or is that an issue?
It is not covered by insurance for bipolar, largely because the FDA has never approved it for bipolar depression. It's a huge shame, and I worry it's really just a financial matter in terms of who holds the purse strings that would allow this to get approved, is they've been more interested in selling equipment than in doing research to expand the uses.
Do you have early predictions of response with any of these rapid therapies?
Yeah, so actually a paper that I just did with Harold Sackheim. Harold, Linda Carpenter, myself, along with Todd Hutton, are members of the publication committee for one of the companies that makes TMS devices. And so we've had access to a database of over 10,000 people treated with TMS. So we're coming out with a whole series of articles, and the latest of which was just published in the journal Brain Stimulation. And Harold, in his inimitable fashion, gave it the title, Know When to Hold 'Em and Know When to Fold 'Em. And what we were looking at is, could you predict responses? So could you predict who was going to go on to respond? And we actually had a lot of good evidence. You can see at 2 weeks and at 4 weeks, the people most likely to go on to respond. The problem was the converse was not true. We were not able to reliably predict who would not go on to respond. We actually have found a lot of material to the other extreme, which is in another paper, we found that there's no plateau effect. Normally, we're treating people with 30 to 36 treatments of TMS. And we looked at people getting more than 36 treatments, and you never plateau. These people who are getting more treatments have less improvement per session than the folks who are responding at 30 treatments, but there is still a likelihood of responding out at 40 treatments or 45 treatments.
Oh, that's very interesting. It just shows there's more to learn. I did notice that article. I realized that phrase came from another collaborator of yours who I've also worked with, John Rush. That came out of the treatment algorithms and then STAR-D. the treatment algorithms that were done in Texas. Well, let me shift now to another rapid-acting therapy, since that seems to be the era we're in. I know you've done a fair amount of work in this, and you've also published the first paper of Psychedelics in Bipolar 2. So I'd like to just switch a bit to talk about your experience with the psychedelic treatment, psilocybin. I think that's the main chemical that you've been involved with.
Absolutely, and I'll also give props to you because you and I came up with a protocol for this study in which we looked at bipolar type 2 depression and found a cohort of folks. We were funded to look open label at 15 folks. The funding was from Compass Pathways, looking at their compound, which is a synthetic psilocybin called COMP360. And we were able to dose 15 folks. It took everybody off all their psychiatric meds. So you can't necessarily assume that you can get folks with bipolar type 2 off meds, but it's easier than getting the ones off meds. I wanted them off for 2 weeks before dosing, except if they were on a really long-acting drug like fluoxetine. I'd want people off of that for 5 or 6 weeks. And we dosed them. I wouldn't believe my own result if they weren't my own result.
They were unexpected. And this is bipolar 2. These are patients with bipolar 2 who have already had a fair amount of treatment. They've had depression for a while. So this aren't young people with their first episode. These are people who've been diagnosed a while and have had many treatments and are quite depressed. And as you said, in bipolar 2, the concerns with taking away, removing the antidepressants, you want to be careful, of course, that they don't become more depressed acutely, but there's not the same risk as bipolar 1.
We found that not only were 12 of 15 still in remission 12 weeks after a single dose, there was no evidence of an increase in suicidal ideation. There was no evidence of any manic stimulation. There was no evidence of insomnia and really pretty minimal evidence of any increase in anxiety. This is an open access article at JAMA Psych, and it was really, really stunning. What you do want to make sure that you're aware of is I'm not eager to extrapolate to bipolar type 1, but for the bipolar 2s, this is really pretty extraordinary, and we're now doing some follow-ups. I've got some funding to talk to these folks 1 and 2 years after dosing, and I have one of my folks reported that she was in full remission for a full 18 months after the single dose.
That's remarkable. One thing about bipolar 2 depression is it's often not remitting almost at all. It can become just very continuous, kind of like the depression we see in veterans, where it's not acute, but people don't remit for 8 weeks. So it's really one very long waxing and waning episode. And I've seen that a lot in bipolar 2. So any period of remission is amazing, let alone that long. So I know we're at the very early period of looking at psychedelics in bipolar disorder. And I think that you focused on safety in this study was very important, because I think that is one of the big questions, how safe it was. And am I correct? I don't remember there were any unexpected adverse events.
No unexpected adverse events we found, and I haven't yet published anything on this, some unexpected positive occurrences, which was a couple of people who had comorbid symptoms on the autism spectrum, and they were functioning better in critical parts of their lives. So a whole lot of stuff I'm not expecting to see, and I feel very fortunate that I have some terrific funding to really try out this very novel treatment on some quite ill folks.
Very novel. And I know you restarted medication on a number of them. How much do you consider their continued stability and general improvement due to the additional meds you started versus psilocybin? I'm not sure one can answer that question, but what's your impression?
In this study, I actually didn't often restart meds for cause. There were several people who wanted to go back, particularly on their mood stabilizer. And as much as possible, we kept people off for at least the first 3 weeks after dosing. But we did start a couple of people back on particularly lamotrigine, which to me is my favorite drug in the bipolar 2s. We were not using any novel medication. We were not putting people on medications that they'd never been on. We were sometimes restarting. Like I said, generally it's with lamotrigine, and generally it was prophylactically and not for cause.
I wonder, just as we've talked about with TMS and VNS, if the lamotrigine is preventing new depression, right? That's its primary function in my experience. And I wonder if taking the psychedelics actually made the brain more responsive to lamotrigine in some sense.
I think it's real possible. I'll give you a really odd example. One of my folks who was not a responder or remitter at 12 weeks, who actually got better for about 6 weeks and then completely fell off, didn't want to participate in the study, didn't want to engage in any of the therapy. And he wound up at about 12 weeks after the dosing having another course of ECT. He had a course of ECT before he was in the study, which he did not respond to. He did respond to the course of ECT after the psilocybin. I don't know that I can explain it. Like I said, he was not somebody who was a responder at week 12, but he did call me up to say, hey, this happened.
Well, I think one of the ideas that's developing around the psychedelics is it may, in some sense, and I use this very generally, open up a window of plasticity where the brain itself has reshuffled a bit. And so things that maybe weren't effective maybe could be more effective now. And on that very speculative note, I think I'm going to end our conversation, which has been very interesting. So today we talked with Dr. Aaronson, and I led us a bit astray getting into vagal nerve stimulation, or VNS. But I think it's a treatment that really has not received the attention, given the potential to help very, very difficult to treat depression and doesn't have a lot of side effects. We then went on to talk about RTMS in patients with bipolar, particularly depression again, and then finished with the very interesting new study that Dr. Aaronson has just come out with in the last few months, JAMA Psychiatry, talking about a case series, a new pilot looking at psilocybin for patients with bipolar 2. So thank you for tuning in. Please take a moment to download the Medscape app if you'd like to listen. The podcast will be available on all formats. You can subscribe to the podcast series on bipolar disorder. This is Trisha Suppes for the Medscape in Discussion Bipolar podcast. Thank you very much.
Thanks for listening to Medscape's In Discussion Bipolar Disorder podcast series with our host, Dr. Trisha Suppes. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on bipolar disorder.